Good morning, everyone. Welcome back to Treat Live. This is the fifth installment of our live case series here at Mount Sinai in New York. I'm joined here by Tino Pena down at Miami Baptist. Welcome, Tino. Good to see you.
Hi,
Uh,
good to
he's
see
gonna
you. And
he's gonna help moderate this live case today. We have a very interesting case here. Dr. Lookstein and Dr. Patel are working on in room one.
I want to welcome everyone to room one here at Mount Sinai Hospital. I'm joined in the room by my close partner, Rahul Patel. And then we have one of our superstar PGY6 IRDR residents, Toyin Dada. We've prepared a very brief presentation here to go over the case that we're working on, which I hope everyone finds very educational. It's a really fascinating case. And Dr. Dada, if you'd be so kind to go over the case presentation.
Sure. So today we have a 72-year-old female. She has a history of refractory hypertension, asthma, H. pylori gastritis treated in the past, CAD, prior stroke, hypertriglyceridemia, and prediabetes. And she had presented with postprandial pain and sensation of food getting stuck after she had a cholecystectomy in 2023. Between that time period, she'd lost 30 pounds in the last year due to inability to tolerate solids. She had an EGD done after that, which showed a hiatal hernia, some gastric erosions, and Barrett esophagus. She had an MRCP following that, which showed pancreatic cyst and stenosis of the celiac artery and SMA. So after that, she underwent unsaid revascularization at an outside hospital, but it was aborted because they were unable to cross the occluded visceral vessels. So here we have her past surgical history. She has an allergy to iodine, for which we pre-medicated her for today. She's on medications such as rosuvastatin, aspirin. She's on 3 blood pressure agents, some asthma medications, and omeprazole. Her vitals at the time we saw her was 150/69, and that was on 3 antihypertension agents, and the rest were within normal limits. At the time of exam, her chest exam was normal, abdomen was soft and non-tender, there was no rebound or guarding. And then obviously we checked her left radial pulse to be able to see if we could do the procedure for today. So we're going to this is a quick run through of the pre-procedural CTAP that we got. And just quickly, the celiac axis is included. So is the SMA. And then we noted that her common hepatic artery comes off of that. Her IMA is also has high-grade stenosis, and she has right renal stenosis as well. And then I have some stills on the next slide for you so you can see it a little bit better. To the left of the screen, that is her SMA, which or celiac artery rather, is just totally included with the SMA in the middle, which is also totally occluded. And then on the right, we can see that her common hepatic comes off of that occluded SMA. Then on the left of the screen, we have
That's
her
supposed
right
to go
renal
off.
artery, which shows high-grade stenosis, and then her inferior mesenteric artery, which also has high-grade stenosis. So she's a 72-year female with past medical history of hypertension, H.
Yeah.
pylori gastritis, CAD, stroke, hypertriglyceridemia, prediabetes. She presented with persistent postprandial pain with concern for
That's it.
chronic mesenteric ischemia and right renal artery
Bring this back.
stenosis. And just to recap, complete total occlusion of the celiac artery, SMA, with replaced
Questions, do I want to go
common
double dutch
hepatic
like that?
artery,
Yeah.
severe stenosis of the IMA, and the right renal artery. And we discussed this treatment plan with the patient, and the plan was to revascularize the SMA via the
Yeah.
transradial approach.
So,
Yeah.
a lot of interesting things going on with this case. And I'm going to go back. Rahul's working feverishly, thank God. But if we could go back to the first angiogram, please, just to show you what we're doing. Aaron and Rahul, can you guys see the
Yes.
angiography, the DSAs? Okay. So you obviously see here that there's a diffuse athero of the infrarenal aorta. Keep on cycling it. Essentially, shelf-like calcification of the aorta. You see this critical narrowing of the right renal artery. You don't see any antegrade filling of the celiac and mesenteric access. I don't think it was, so clearly delineated on the CAT scan, but there's critical stenosis of the IMA also. You see a hypertrophied arc of Riolan and then a distal reconstitution of the SMA. What's very interesting in this case, which hopefully will lead to some, fascinating conversations in just a moment, is that really not only the entire midgut is coming off of this SMA trunk, but also the foregut, in that the common hepatic artery, when you really map out the CT scan, is coming off the SMA. So she really needs this SMA done for her to get, I think, really durable symptomatic relief, and which is why we've been sort of feverishly working on this so far. This is a oblique angiogram, and just to back up a little bit, we placed a 5/6 slender sheath in the patient's left radial artery, and the previous diagnostic angiogram was performed through a 5 French Serra radial catheter. This is now a 6 French 100 centimeter runway guide cath in an MP1 configuration from Boston Scientific. We've advanced it down to the again the visceral aorta, and we're trying to find something that appears to be like a nub to get into this large SMA trunk. Here, we're sort of floating down, and you can see that right renal artery. And I think if this case goes relatively quickly, we'll probably end up treating the right renal artery today also. But obviously, we're here very focused, laser focused, if you will, on the superior mesenteric artery. And again, we're just trying to get our systems in place here. We're starting to see some semblance that there's a little bit of a nub probably there in the center of the screen. And again, we're just getting closer next. And sorry, if you go back a little bit. Yeah, there. So here we have a guide. And, Tino, I'm really looking for you for a little bit of guidance here, but we have two 018 hydrophilic wires in tandem that we're using in like a stepwise approach to try and get traction. So one will maybe, bite a little bit on this CTO. We'll escalate the guide maybe by 3 or 4 millimeters, try a second wire, and then you should sort of use them in tandem. It's one of the benefits of working through a guide catheter like this. But, Tito, I know that you and your group do, renal artery occlusions and visceral artery occlusions. What's your setup for something like this?
No, I think this is a great way to think about, how to maximize your pushing power. A lot of people still, when they're talking about other type of approaches, want to make sure that they continue to have the ability to and to have a good amount of push. And I think having the two wires and be able to escalate is a great technique, the way you just showed it there, and be able to get across. So I think that you really kind of showed a good idea
Mute
and
this
a
one.
good way of doing that. And now you have a better chance of maybe advancing even a little bit further because you have the two wires. So I think it gives you the benefit that you can
So
step.
full transparency, as usually happens, I'll try for 5 or 10 minutes, which I did off camera, and then Rahul will come in and be able to cross in about 3 minutes. And so while we were checking, Rahul was able to cross, and so you can see here that we're through the CTO, and we actually have both wires through the CTO. And so that was again, working in tandem, a V18 and a Command 18, and here's the AP view. So again, I'm just going to throw it out there, Aaron. What would you do at this point? We've got a CTO. We've got decent working wire across, which is an 018 wire of note. I don't think we need that necessarily. I think we,
18.
probably we can take one of them out.
Okay.
Uh,
Take
but I'm just curious what you would do.
So, Rob,
No,
is your plan to work over one of these wires, or do you wanna try something, or are you thinking of switching out to a different wire potentially to work over?
Well, again, I'm open to anything, but I figured I would open it up. And I think that none of the sort of options right now this second are really ideal. We got to think long and hard about what we're doing.
Not really on
You know,
is that the wrong rates?
and
Well, in
I think
terms
you
of the
just saw this
diameter
angiogram.
Should actually
in
go the
in
opposite way,
in
right?
terms of the diameter of the wire, right, I think you mentioned that both of these are 018 wires, right? And I think
Yes.
at this point, we probably wanna think about, let's work backwards and think about what we wanna ultimately place stent-wise into this vessel. We should probably talk about the different options and what's available currently on the market, and then work backward and decide
I
what
think we're
wire to
losing
place.
one of these branches down here.
What do you think, Tino?
I think that's the way to think, right? Are you thinking here of a covered stent or a non-covered stent? Are we using some of our traditional stents? I've had trouble putting our traditional stents through that runway. So you may have to go to something,
Yeah, take if we get
lower
further down,
profile, but that's
should we
just
wait
been
till we
my
get the V
experience. And then what do
the
you want to do
stabilizer
to
down?
once you decide what you want to do, how are you going to prep the lesion? Do you think you need to prep this or you want to go primary stent.
It's open. It's open on the table underneath the.
I think we're gonna need to prep it. That's
Mhm.
my 2 cents, and, we're all set up to do IVUS also if we think that's gonna be helpful, but we're thinking we're gonna probably pre-dilate it right now. I'm curious as to what you guys think about pre-dilatation, what you would do.
So I like the idea of pre-dilatation, Rob, for a couple reasons. Number one, I think this is a really rocky shelf, and it's going to be hard to get anything to pass through. So I'm curious to know what balloon you're starting with, and then number two, we could potentially, once we have a bigger channel, we could send out an 014 wire potentially, and then put down, a number of different stents that I think we have in the lab.
So,
Yeah.
again, what size would you pre-dilate if we're thinking that's a good idea right now?
I would say maybe 2 millimeters, something like that, maybe three.
Pino, what do you think?
Yeah, I didn't get a good feel from the CT. I mean, the CTA looked pretty bad, and it looks like you're fighting there, so I think it's pretty tight. I think there's 2 questions. What balloon is actually gonna go through that follow that wire? And then
We're about to
what
find
you
out in a
need
second.
ultimately. And a lot of times what you wanna do is sometimes you need to get your first balloon just to create a little channel and then step up. Sometimes we try to do it all with one pre-dilatation. You may need to prep with a series
So
of
you want to see what
balloons.
it is?
In these situations, we've actually tried a couple of times now. I think it's an off-label use of the coronary shock wave when it's really calcified.
That's
And
not a bad idea.
again,
It's
it's
a
an
great idea. Yeah, yeah.
anecdotal experience, but it does go well over the wire on that 014. So
Okay,
I'm
so are you guys able to see our live feed right now?
Yeah, we
Yeah, it
see
looks
that.
good.
What size
Okay,
is that,
so that
Rob?
was a 30 by 20 millimeter 018 Sterling balloon,
Right.
which tracked perfectly.
Should we go a little further?
Okay, and we're going to send it out just a hair further, just to make sure that we have enough room to work here. Okay, and again, it's working well over this 018 wire.
Should we get the origin again? Here you go.
And then we're just gonna probably hit the origin on the way back just to make sure we've got some working space. And then we're gonna see if we can float down a workhorse 014 wire to Aaron's recommendations just to try and get something a little bit more stable down here. So again, it's nice to have a whole inventory of balloons here ready to go.
Now
And we're
now,
gonna,
Rob,
again, get
you
this
you
balloon out
mentioned
of here.
you mentioned this is a Sterling wire. There's different just for the
Sterling
audience.
Sterling Sterling
Sorry, Sterling
Sterling
balloon.
angioplasty balloon.
Um,
Yep.
there's different types of balloons for these types of applications, and so I know that we have a rapid exchange platform and an over-the-wire platform. Do you or Rahul want to talk about? I don't. I think you guys are using a rapid exchange, although I can't tell exactly.
That's
You want to
absolutely
talk?
correct. Our default for all of these cases is to work over rapid exchange platform, especially if we're working radial. We feel it makes the ergonomics and the workflow much more efficient.
Can we go up on front flush
Most
too?
of both Rahul and I, were more or less, very well trained in a multidisciplinary format with both radiologists and cardiologists. We've largely migrated over completely to rapid exchange
200.
platforms. And so we feel that that's a very, very good platform to work over for this.
Tino trained me well.
Yeah. No, I think that
Um,
strand balloon is a great choice. I think it tracks really well. I think an 018 and rapid exchange, you saw how well it went down there and was able to read the profile really well. When do you start thinking about where do you want to start and end with your stent and when do you start considering how far do
That's
you
it.
want to cover into the SMA?
Well, I'm hoping we can talk about that in just a minute.
Gonna-
Okay.
Ready?
So I'm
I
just
think we
gonna,
probably need
yep, I'm
better
just gonna
imaging to
map
sort of
this
figure that
out.
out. Yeah,
All
there we
right.
go.
Still not quite where I want the wire. It's fine.
S So that,
I
one of
would
the
say
things
we
that
can
I was
redirect
thinking
it down the
about
main
when
trunk.
Tina, when
Yeah.
we were talking about the different types of balloons, rapid versus over the wire, a lot of people still approach this case from a femoral approach, and I think, one of the things that we lose a little bit with rapid exchange is that pushability. Even though this is a really good platform, sometimes there's issues with pushability, and I think if you were approaching this potentially
Okay.
from the femoral artery, that might be a concern, whereas I think with the radial approach,
I'm gonna tail
and then
these.
obviously years ago, we used to do this from a brachial approach. Um,
Wrong one.
limits some of the ability to get a rapid exchange across these lesions. What do you think about that?
Yeah, I agree with you. And I think, we can't underestimate the power of that guide cath that you
What'd you
have
take it
right there.
from?
I think that's really giving you great support. So even though you feel like, hey, I'm farther
We start
away
getting
than
the
I would
5
from a
micron.
femoral approach, your angles are beneficial and your support is
Can we get
almost
a
in line.
5,
And I think that's really the point you're
a
trying to
520
make.
Megatron?
And I think you definitely see that you get that wire to go, plus you have that pushability. It's almost a straight shot.
I wrote the guide down, right,
Yeah.
pulling down.
I
Gotta
think
get
these rapid exchange systems now are so, you know, they just really slide in pretty easy. And I think that's also a
under
huge
around.
Yep.
benefit.
Okay.
Yeah, they're very low
All right. So
profile.
now we've got a coronary wire down. You can see we've got an 014 wire down in the iliocolic branch in the right lower quadrant there. And again, to your conversation, it's pretty nasty, SMA CTO here. So the question is, what do we want to do?
So let's just start with basic stuff. Anticoagulation. I'm assuming you're fully anticoagulated. And I know you
Yes.
very well. I know the patient
Yes.
was on aspirin and
Exactly.
whatever
Yeah, so she's gotten
beforehand.
about 5,000 of heparin total,
Uh,
and she's yeah,
Right. So we have full therapeutic
we
anticoagulation
gave
on
3.
board,
I gave 3.
and I think the question is, do we continue to vessel prep? What's the implant we're going to put in? We haven't even gotten into whether we're going to think about reconstructing the hepatic or not, or whether we're just going to focus on the SMA. These are all really good questions to start thinking about right now.
Why don't we talk first about the hepatic? How is her liver getting perfused right now, Rob? Do we have any pictures of that?
Well, obviously, it's a CTO, so it's predominantly getting perfusion through a very hypoperfused hepatic artery, where the pulse pressure is probably on the order of 40/20 going through a CTO, and then predominantly the portal vein. So that's just one theoretical question of whether or not it's even worthwhile to reconstruct the hepatic, or whether we should just really focus on the SMA, since we're treating her for chronic mesenteric ischemia and she has no signs of hepatic dysfunction in the setting of this hepatic artery filling through collaterals. So I'm gonna pause for just a second. Tino, I want to ask you, we're going through a SMA CTO in a we didn't go into this so much, but a very, very petite woman. And we are, um, uh, you know, uh, working very, very diligently. You could see the vessel prep was, nice, but not ideal. What do you think for implants here?
So I think for implants here, I still like the non-covered balloon expandable stent here. I think it gives me a lot of different uh, opportunity and a lot of different options. I think a covered stent, I think you can't argue with that, but I usually keep that as kind of in my back pocket if I really think I need it, if I think I'm going to really have more of a complication. I think our rates of patency have been pretty high just with balloon expandable. So I usually go with that. If I go with a small stent, which I try to avoid, then I start thinking about a drug-eluting stent or coronary stent. But usually I can get into something a little bit bigger.
So, Tito, I'm so glad I asked you that question, because we're literally right about to put in a coronary drug-eluting stent. This is a 5 millimeter Megatron stent. Obviously, this is an
Great.
off-label use, but this is a 5/20, and I suspect we're probably going to need to have two telescoping stents here. We've actually been using this implant fairly regularly for
Under run.
renal arteries and for visceral artery CTOs. We find it's been working very, very well. And we think that that's probably a very safe way to go here. Obviously, it tracked very nicely through this 6 French guide.
That's
Well,
great.
that's
I
the
think
other
that's
thing about that product, right, Rob, is it's very, very, very trackable, probably better than some of the non-coronary ones that we've used.
I love the
So we're
choice because
just
I think
mapping it out. We're just mapping out how distal we want to go. We want to get a lot of different obliques to make sure we're not fully covering visceral branches.
This brings up
And
a really good
so
point,
far,
Rob,
I
right?
like this.
Yeah, I
Yeah.
maybe a
So
little
far,
bit
I
further
like
in.
this,
What do
but
you
what?
think? A few
Okay,
millimeters
all
in?
right,
Yeah.
Tina, what do you think?
Yeah, I thought so. On the other view, I was still worried about the little branch. So a little bit further in, I think I like. But I love this stent. I think it's the best of both worlds. 5 millimeters, but still still getting the
Give it
coronary
a little
advantage
further
of the
in.
drug
You're gonna
elution.
catch
I
the
think that's
sledge, right?
great.
You're gonna need 2 anyway, so really what I'm looking at when I place these is the distal location
Right.
first, and then you're gonna have overlap for the proximal stent that you're gonna place, I think, second. So really what I'm looking at
What'd
is
you
that
guys
distal
think of that
marker.
run?
I think that looks pretty
What'd you
good,
guys think of
Rob.
that run?
I think it looks good.
Okay, Tina, what do you
Oh,
think?
good. I do too. I think you're past that, before that branch.
All right, we are going to go. Now, this balloon at burst pressure goes up to 5.4, and that's 16 atmospheres. You
12.
can also dilate it basically up to 20 atmospheres, and that's a
We're at
5.6,
12.
which is probably a good. I would say we should go up to 16 to see how that looks. We can always post dilate later on, but so 16 is essentially a 5.4 millimeter balloon expandable stent. And we're going to need the second stent soon. Let's manually take this down.
So Rob, what was the diameter of this vessel when we measured it on the CT?
It was just over 6.
Okay. So one so this is gonna probably be around 5.5 or 5.4-ish, right? Right after that
Yeah.
16
indication?
is, yeah, 5.4. Yeah.
And
Okay.
then, what I think we could do if we're, very efficient with our time is we could IVUS this afterwards just to make sure that we have good wall apposition with the stent, and see how that goes.
I think with the amount of calcium that you have in there, I think this size is going to be great. And remember, what you're trying to do is just really increase some antegrade flow, and she's going to do just fine.
So it looks like the next stent's gonna be a little bit shorter. Or are you gonna try to use something similar and just overlap it?
I think we're going to use something similar and overlap it. And we're going to go back to that same oblique where we're able to see almost like a true lateral. So there we are. And you can see we got to go right up to that big shelf of calcium that's right there. So I think the 20 is going to be the right size. That last stent was a 20. This new stent's going to be a 20. If I had to guess, our total coverage is probably going to be just under 4 centimeters.
Yeah.
So, just, I guess, point of contention, right? So you're doing two drug-eluting stents with a lot of overlap, theoretically, concern about too much drug or.
Again, that's a theoretical concern. I personally have not heard that that's a concern with these polymer-based stents. The nice thing about the Megatron is it's a abluminal-based bioabsorbable polymer. So the polymer coating's relatively low. The duration of the polymer is relatively brief. So that's what we're looking like. What do you guys think?
I think I would pull the guide
I'm
back and
gonna
take
have to
another
get this
quick
bet.
look.
Yeah.
But, that's a
Yep,
great
so that's
technique, Rob. I
exactly
I
what I
think
did.
I think what you're demonstrating here is using and this is what Tina was mentioning before,
Yeah.
using the
Or
guide to sort of give yourself pushability into that calcified lesion,
where'd you run?
and then once the stent's in position, pulling the guide back and taking a picture. That looks pretty
So what do you
good.
guys think so far? In
I mean,
in
that
in
almost
like
looks
Great.
2 more
perfect.
millimeters,
I
something like
think
that?
great.
We can go a little bit more oblique. I can get you.
Right. I'm
It
gonna
looks like you
advance this
got
second
a
set a little
millimeter,
bit more,
looks like a
like
millimeter or
that.
2 in the aorta, right? It looks like
Yeah.
that.
Yep, I like
That
that.
looks that
What do you
looks
guys
really
think?
good. I think it looks great.
That looks great. I think you can
Okay.
always go a little bit more in the aorta if you want, but I think it looks perfect. I like the overlap there.
We'll probably do a little, I guess, stent cell in the aorta, right? Then we can go.
Yep,
Maybe
we're gonna
maybe
go
maybe
here.
maybe one, yeah, that's probably a little bit better.
I'm gonna put a little bit of forward tension on it.
Oh no, that's too much. Now you popped in, right?
Okay, so now like that, right?
Yeah,
Okay,
there we go.
let's go.
Ready?
Yep.
The other nice thing about this stent, and we probably should talk about that, is you're
16.
gonna consider maybe plus or minus IVUS, whether you're gonna go back in maybe with a 6 millimeter balloon and post dilate it, and this stent can go up. I believe this can go up to 6 without an issue, right, Rob?
That is correct. You can take it up to 6.0 without disrupting the polymer at
Let
all,
me just do
which
this.
is a very, very nice, uh,
I see.
property of it. Um, People have anecdotally told me you can go slightly above that. I wouldn't recommend it, obviously, but I think for the purposes of this patient, we're trying to, get it to 6.0 maximally and hopefully allow her to get some relief from her mesenteric
I
symptoms.
got the guide.
Do you want to talk a
I
little
just
bit about our anti-platelet protocol with these stents and whether it's different than if we're using a bare metal?
I mean, I think it's, obviously, drug-eluting stents in the visceral circulation is off-label. We all have anecdotal experience. This patient has significant athero, obviously. I think dual antiplatelet therapy here is completely reasonable as long as she can tolerate it. And then we need to make a decision about how long it's going to be,
Do a run.
and take it stepwise from there. I see that interesting little waist there on
yeah,
the
that's
on
probably
Wow.
the
So that's
osteoplaque.
yeah, that's pretty
Can we get like
nasty.
a 6 sterling?
Yeah.
I like
Can we get a
Rahul's idea.
620 sterling?
Put a six in. I think as we were just talking about taking a six balloon, it's not going to disrupt the
Yeah.
polymer, and you're probably going to be able to get a little bit
A
better
lot
wall
better.
apposition with that calcium.
So you
Are
talked
you
about
concerned? Sorry, go ahead, Tino. I didn't mean to interrupt.
abdominal, the polymer. I think that's something that people should understand, that the polymer is only on the
Close for a
vessel
bit.
spine,
We get some bigger.
basically on one side of the
let's do
stent.
this.
Right.
Can we get the 018
So,
IVUS?
what's nice here is obviously we've opened
IVUS.
up the superior mesenteric artery. We have not covered any of the visceral branches. And I think you see off this angiogram, there's a very nice inferior
Yeah.
pancreaticoduodenal artery
Okay.
coming off
Mm.
just distal to the stent. And as you watch the angiogram, it's actually very nicely reconstructing the gastroduodenal artery, and a little bit later on in the run, you're seeing the hepatic artery fill antegrade, okay? And obviously, you get a sense of how proximal that common hepatic artery is coming off of the SMA. And obviously, there's a CTO for that artery as well. We were Rahul and I were talking before we started the case about whether or not we could go after that common hepatic artery occlusion. I think just as an idea, wiring through all that to try and get the hepatic artery antegrade is probably not going to really benefit this patient right now. And so I hope you all agree. I don't think we're going to
Yeah.
try that today.
I agree,
No, I
definitely.
agree.
Take the win.
Yeah, I mean, look, I mean, she was fine without any antegrade flow, and now you have some. So I think her liver is going to be totally fine. There's no reason to do that.
Exactly. All right. So as I promised, we're going to use intravascular ultrasound here, and we'll show you what the artery looks like. And this is a 014 volcano wire, the PV014. And one of the nice things about having a Philips platform, and in full transparency, we have both Philips and Siemens equipment at Mount Sinai, but room one is a Philips flex arm room, and it's a fantastic room for this kind of complex visceral work. But we have integrated intravascular ultrasound, and
Hold on one
it just
second.
makes it very, very, very user friendly.
Gotta
And
move
we
this.
obviously think IVUS is incredibly valuable, especially when we're talking about putting in drug-eluting stents and other complex implants. Vessel sizing becomes, critical.
Well, also not to mention the dose in this room is as low as you can probably get at this point with the current
Yeah.
technology. And a lot of these cases where we're going in lateral to do SMA work, the dose can get pretty high, particularly in larger patients. Luckily, she's not a large patient,
Yeah.
but as you know, this could be a very high radiation dose case if you have older equipment.
I'm gonna show it
Man,
backwards.
that looks pretty good.
Okay.
Yeah,
All right. So this is the distal vessel,
I don't have
and again, you can see there's almost like an inflammatory process. The athero is so dense here distally. You all can see the
yeah,
IVUS clearly,
Yeah,
right?
we
that's a
see it
great
really
Okay.
example of
well.
that.
So
Yeah.
Yeah,
I gotta go the
and
other
you're
way.
outside the
I'm
stent here.
gonna
It almost looks like you're in a
yes, we're
stent, Rob.
outside the stent. So can we pause this and measure this diameter here?
I should be able to do it here.
because I think that this will be helpful. And I would ask for outer wall to outer wall. Can we do outer wall to outer wall? That's inner wall to inner wall.
So that's
That
4.
measured about
4, 4,
4.
4.
So,
Yeah.
5.5 for the inner lumen. Let's do, yep, right at the dark gray.
Further in. Nope. No, no, no.
Nope,
Right there.
right there. Perfect. Yep,
There.
yep, exactly. What is that?
6.
That's about a 6 right there. Okay. Now, again, we've taken it to 5.4, right? And so I'm going to pull back a little bit now until we get to the stent edge. Again, you can just see this diffuse process. And this is right at the stent edge. Again, you see the diffuse athero there. And
It's
now the
this is a great
stent,
example, of what you're describing here, right? I mean, this is the kind of stuff that I think the DES is probably really helpful for,
Yeah.
potentially.
oh, there's no question. So, Aaron and Tino, we have clearly wall apposition into the athero, but should we deliver the stent a little bit more aggressively? And then I think if the fluoro image is showing also, I'm pulling back into that waist that we have on the stent, which I think is going to be right about here. Yeah, see that waist on the stent right there?
So
So
I
I
think the
think,
answer is gonna be yes, Rob, and the reason I say that
yeah,
is
we're
because you wanna sort of push the stent up against that inflammatory process, but also I think you have that waist at the top. The only downside in my mind would be maybe a concern about vessel rupture up top.
record.
Can you
What do
hit
you think,
record?
Tino?
Yeah, I think that's the exact discussion, right? Are you gonna take a this is a pretty much a winning hand. I don't like the compression of that osteal plaque. I think we can touch that up with a 6. I wouldn't probably go too far into I definitely don't want to extend beyond the stent. I
Yeah.
would probably not go too far
You can
into,
stop
far out,
stop
but
recording.
I think I think it should tolerate a 6 and then I would get out.
Let's talk for a second
Okay, so
about bailout, Rob. You wanna
can we have a
just tell us
620 balloon?
if
So
you
yeah,
do
so
have
if
if you
if
do
we
have
were
a
to
vessel rupture here, let's talk about how you would manage it.
so luckily the new VBXs, the 6 will go through a 6 French sheath. So we could theoretically put an R2P sheath down, right? A 6 French R2P sheath down and then deliver a 6 VBX down. We'd have to go very fast,
So have a
obviously, because we have to
620
switch
oh, we
out.
have a 620 Sterling? Fabulous.
We
Yeah,
have to
and you'd
swap out
also have an
everything,
014
right?
wire, so, yeah, that's gonna be a
Yeah, yeah.
tough
So we would, but we
tough thing
could
to
do
do.
that because we have the guide. We could just swallow the guide. Um,
Push the guide
push the guide
across.
down, switch it out. Yeah, put a
Yep,
rosin down, and then just deliver an R2P sheath, which we have, and we have the VBXs.
okay.
So
But that's a really good
sorry,
teaching
my
point. I
mic's a
think,
little bit.
one of the things that we're always talking about with our trainees is what's the worst possible scenario and are you prepared to manage it? What do you think, Tino? Is that how you
I
would approach
think
a rupture?
that's exactly how would approach a rupture
Here,
here.
come
I
here.
think the 6 French VBX has kind of been a game changer for that. And I think you're ready to go. You're exactly right. Have the 6 French sheath in the room and you have a
As
plan.
far
I
as I
think
can go
that's
in
the
terms of
key.
mag.
Like that plan. And I think that's exactly probably what we would teach too.
Yeah, it's interesting. We had a little bit of a ledge effect on the edge of the stent, which again just gives me more
Back it up a little bit.
support that I think we have to
Put
post
this as
dilate
back as you
this.
can get.
Okay.
Rob,
I'm gonna
what's
back
the
it up so
balloon that the
you can see
Megatron is
the.
mounted on? Do you know the technology on that for us?
It's the coronary platform from, Boston Scientific. I don't think I could accurately
There we go.
represent
Right.
the exact platform, but it's obviously, the Boston Scientific
Down.
coronary platform. Obviously, you all saw that the 6 went right up. There is some recoil still, interestingly. I'll take a snapshot of that.
Yeah, I was gonna say take a 1X. It
All right.
looks like there's a lot of plaque there. Wow.
Yeah. But I
Yeah.
think we
So why
made
don't we take it up again and leave it up for, a good 30 seconds. All right. Take it up to 12.
And just for the
definitely got
audience, the
some.
Good.
patient's
All
fully
right.
heparinized for this, obviously.
That is absolutely correct.
Mhm.
All right. And we always target for these cases an ACT between 250 and 300.
Although
You
the one
said you
good
want
thing here is we already know she's collateralized, so I don't think she's gonna thrombose distally. But
which workhorse wire are you using, Rob?
I have a personal preference for the,
down.
interestingly enough, a,
I can take it down.
cordis coronary wire, which is called stabilizer. And the reason I like that is it's a very, very short transition. There's a 3 centimeter transition. I know a lot of people like wires like Spartacore, which is an excellent wire, but from Abbott. There's the Grand Slam wire, which is, a really good support wire, 014 support wire from Asahi. I think these are all excellent wires. The Cordis, I just think in my hand, because of that
Definitely.
short transition, it allows us to do relatively complex renal work, relatively complex visceral work, and as I said, I'm pretty fond of it.
What do you
Good
use,
one.
Tino?
Yeah.
Yeah, we use a grand slam, but I like the short, the concept of that short
Okay.
transition. So I
We're gonna mag up one.
always learning, always learning.
No, looks good.
Looks pretty good to me, right?
You can
See
see
the
the
liver.
liver
And
woke
and you
up
see
too.
the hepatic coming up pretty quickly now. It's actually faster than it was before. I, for
Would
one,
you
am
do
very, very happy
Yeah,
here.
I think
this is
it's
a
a
great
great
result.
result.
The only thing I would maybe add, Rob, is just an aortogram just to
Yeah.
look at the arc and see if, there's maybe reversal of flow. I don't know. It's something to think about.
I mean, we could also just go down and wire the IMA right now, but,
To what end?
I don't know that it's gonna change anything that what we're gonna do. And actually, if you really look at this SMA angiogram, you're actually seeing the middle colic,
Yeah.
um, fill the
Yeah,
splenic flexure antegrade. You see that
yeah,
coming up there
Yeah.
in the
yep.
upper right portion of the film, right? So, again, I'm actually thrilled. We didn't cover the inferior pancreatic duodenal. We didn't cover the middle colic. Our stent column, really just covered the entire length of the CTO, and obviously it was about a 4 centimeter CTO. And I'm actually very, very happy.
Yeah, it's a great
Well,
result.
I think this is a great
And
result, Rob, and you didn't have to go to the IMA, which is, I think, a great strategy here. I think I might have gone to the IMA first to try to dilate a little bit and get myself some patent vessel just in case my CTO didn't go as well as it went for you guys. But in retrospect, I think you guys really showed how you can not even touch the IMA. That's your lifeline. Stay in your SMA, get a great result. And I think this is great. I mean, I think she's going to get a lot better.
yeah, I totally understand the strategy of sort of taking the low-hanging fruit first and then tackling something more challenging. I think for today, to your point, the IMA, that's what she's living off of. We didn't want to touch it. We've got the A team here today. Everyone's working so hard to take care of this patient. And, lucky for her, we were able to collaborate together, get the SMA open, and I think she's going to feel just a whole lot better.
Show your radial setup and how you're working where the arm is really
Yeah.
close. And I think this is really important.
Yep.
People do radial procedures, how to position the arm,
Sure.
how to get going. I think there's a lot here.
So, we have the arm not 100% tucked in. It's probably at a, 20-degree angle off the long axis of the patient. We've got a 5/6 slender here in the wrist. This is our MPA, MP1 6 French guide. This is our 014 wire setting here. And so, we're all set up almost like it's femoral access. And obviously ergonomically, we're really working like we were working left femoral. And we found over the years it's a much more ergonomic way to work. It allows us to have full access to the patient. Very importantly, we want to have our anesthesia partners to be able to have access to the patient also. And then again, Tino, you and I spoke about this. We really love this flex arm configuration because it really optimizes everybody in the room, the nurses, the technologists, the physicians, the operators, the anesthesiologists, to be able to have unlimited access to the patient. And that's one of the real great benefits of having this room set up this way. Thank you all
Thank you.
so much. Thanks for joining us. And we look forward to seeing everybody next month.